Good evening, Endo Summit Live, and welcome to one of the most anticipated webinars of the 2024 season. Tonight, we are talking all about thoracic endometriosis with two fantastic endometriosis excision specialists. From Atlanta, please welcome Dr. Ken Cernovo. Dr. Cernovo, do you want to introduce yourself?
Sure. I'm Ken Sonervo. I'm director at the Center for Endometriosis Care, where I've been for 23 years. I did a fellowship in minimally invasive gynecology in 2000, and then started in practice specializing in endometriosis, specifically more difficult endometriosis, including a lot of thoracic endo and a lot of bowel endometriosis over the years.
Excellent. And also joining us from the West Coast, where we are very appreciative because of the time difference, is Dr. Shante Moling. Dr. Moling, do you want to introduce yourself?
Sure. Thank you so much, Sally. So hello, all of you. I am Shanti Moling, and I am currently in Portland, Oregon, and we've been having some dreary gray weather. I came late to minimally invasive surgery and endometriosis. I had a full career as a generalist and kept coming back to pelvic pain. And so kind of at a later age, I went, I think your dog is very interested in hearing what I have to
That's my
say.
buddy. That's Finley. I love Finley.
I did my fellowship in minimally invasive gynecology starting in 2014. So switched from being a generalist, taking care of all those things that affect us, and refocused my career in pelvic pain and endometriosis. I'm now located in Portland, Oregon, and have been working with Nick Fogelson at Northwest Endometriosis and Pelvic Surgery for the last 2.5 years. And it's been a great journey. My focus tends to be more advanced cases of endometriosis, including bowel disease, including thoracic upper abdominal disease. And so my journey hasn't had the depth that Dr. Sonervo's is. It has just a different perspective of doing these things robotically and really recognizing this often unrecognized disease and learning to listen and then find it. So there we go.
Right. The puppy has joined us, and like all puppies, he wants you to throw that toy. It's very, we had to tell Dolly, which is my puppy, that the building doesn't allow toy throwing after 8 p.m. at night, which of course,
He's happy just chewing it, they're still
trying to get her to buy into that. All right, so let's get into the nitty gritty. What is thoracic endometriosis syndrome? We'll start with you, Dr. Cernovo, if you want to help us out with a definition.
Well, really, thoracic endometriosis syndrome is a group of different presentations of endometriosis that involves either the diaphragm or the lung. And so really there's 5 different entities. There is diaphragmatic endometriosis, which is probably one of the more common presentations, where patients have a lot of either chest pain, shoulder pain, or rib cage pain. Predominantly on the right-hand side and occasionally on the left-hand side. The second most common presentation is catamenial pneumothoraces, which is a bit of a misnomer because about 2/3 of pneumothoraces related to endometriosis actually occur outside of the menstrual window. And because of that, it really kind of leads thoracic surgeons to misdiagnosed and probably underdiagnosed a lot of endometriosis related collapses because it's not occurring during that menstrual window that they're normally taught is related to endometriosis potentially. The next most common presentation is probably something called a hemothorax, where a patient has bloody fluid within their chest. Their lung is usually partially deflated on that side. And they often will have reduced lung capacity. They'll have chest pain. And those tend to be the most difficult types of cases to manage because often it'll be a very chronic issue, especially in patients who've had this going on for many, many years, and it's been left untreated, where the lung itself does not expand quite as well as normally. And because of that, what we have to do is we have to actually remove the outer skin of the lung as well to try to help it re-expand. And it usually involves much more extensive resection inside the chest wall as well. The next presentation is catamenial hemoptysis, which is related to coughing up blood during your menstrual cycle. And this is a pretty rare presentation. It's usually typically involves younger patients, usually on average in their 20s. And then the last category are patients who have pulmonary nodules, which if you look on an X-ray, they kind of have this ground glass appearance because of the bloody fluid within that nodule. MRIs or CT scans will also show these nodules. They usually have to be above a certain size to be considered related to endometriosis. Pulmonary nodules are relatively common. They're often related to infection at some point where there's been some scarring or, what we call some granulomatous changes related to kind of a chronic infection and the inflammation associated with it. But endometriosis related ones are relatively uncommon.
Excellent.
Nice.
Dr. Mullen, go ahead.
Well, I love it. And in fact, what I want to do is screen share because it's almost as though Dr. Sinerva was following my key points. So some people I think are more visual. And so let me see if I can screen share. Hopefully it's going to work.
You should be on because I allowed it.
Yeah. Okay, I'm going to reopen. I might lose you for a second.
Don't lose us. We're gonna chat. If we lose you, we'll chat till you get back.
Okay, chat till I get back, and then I'm going to go over those key points again, and it's going to just cement that all in because there was.
So, Dr. Sinerva, what kind of symptoms do patients come to you with when they talk about when they think they have diaphragmatic endometriosis or thoracic endometriosis?
Most commonly, they present with chest pain. So it's not uncommon to have a lot of shoulder pain or scapular pain related to the shoulder blade. That's the most common presentation that makes us really suspicious. And the reason for that is the diaphragm is innervated, or its nerve supply comes from the cranial or the cervical nerves C3, 4, and 5. And those are also the ones that innervate the shoulder and the shoulder blade. So it kind of fools our body into thinking that the endometria or the problem is actually in your shoulder when the problem is kind of being referred from the diaphragm. As well, patients will often kind of complain of just generalized chest pain, or if they have endometriosis that's involving the lower part of the rib cage, they'll often have pain that localizes more to that area. So it can really range from, bottom of the rib all the way up to your shoulder. Some patients mention being short of breath. And I don't think the disease process itself usually causes an intrinsic problem with the lung. But I think what happens is because patients are guarding or preventing, they don't want to take a really deep breath because that makes their pain worse. And so what they do is they tend to not take as deep a breath, and that kind of gives them this feeling of being short of breath. There really shouldn't be, for most patients with diaphragmatic endo, there shouldn't be an actual problem with the lung itself, the great majority of the time. Every now and then we may have some disease that may be really deep on the diaphragm that may extend onto the bottom portion of the lung, which can be removed during a thoracoscopy as well. But that tends to be the exception rather than the rule.
Getting a little worried she isn't back yet. So I have a question. How do you tell the difference? Is there any way, before we talk about imaging, just through symptomology, to tell the difference between if somebody has diaphragmatic endometriosis versus thoracic cavity endometriosis?
Well, diaphragmatic, again, will typically be more shoulder blade related. thoracic endometriosis, or involving the chest wall, will typically be more diffusely involving the whole chest, and so it'll be less likely to kind of present with that shoulder blade pain that we could typically see, and so they may have kind of more generalized chest pain. It's pretty uncommon for us to see central pain associated with endometriosis, because that's usually taken up by what we call the mediastinum, and that's made up of the heart and the esophagus and the trachea and all those things in the midline. And endo very rarely gets into that area, other than maybe the pericardium, which is the sac that kind of surrounds the heart on the undersurface of it, or even less commonly in the chest side of the pericardium.
Yes, excellent. All right.
Okay. Oh my gosh, I had to go through a whole rabbit hole to do this, but now let's see if I can screen share. And it looks like I can. And so here we go. So I want to kind of restate those things, and then I want to move on as I've been listening, because I love what Kenny Sinervo was saying. So traditionally thought to be very rare, we now know that at least 12% of patients with deep infiltrating endometriosis have the disease. That just solidly validates what Dr. Sinervo said. The majority of extrapelvic disease is going to be diaphragmatic or thoracic, and 80 to 90% is on the right. So as he was also talking about, one of the primary symptoms is having this chest pain. And, it isn't always just chest pain. And I think as I was gone, you were talking a little bit about this sort of subclavicular pain and subscapular pain, but also I've had patients who have this flank pain just beneath the rib cage, and they may also have pelvic disease that might be thought to be referring there, but it turns out sometimes that is diaphragmatic disease. So catamenial pneumothorax in 41% of the patients with intracavitary disease, and as you also pointed out, non-catamenial pneumothorax in 25% of cases, and hemoptysis in 5%. So really, when you're talking about pneumothorax, like what is pneumothorax? I think it's really important to understand that you have this lung cavity that's in this very beautifully sealed pleural compartment. And if there is a defect in the lung, you get this extra air that then decompresses the lung so you can't breathe as deeply. And you get this pretty significant shortness of breath and pain. So I'm going to take away my screen share for now so we can go back to our discussion. One of the things that I heard you talking about, and that is really I'm on a mission about, is the fact that patients who present to an ER with these pneumothoraces so often get routed, so often, 95% of the time, get routed toward cardiothoracic surgery. And then they end up in this other system where endometriosis is forgotten, not known about, and not even acknowledged, or maybe like, whoa, surprise, written up as some kind of case report, when that's the culprit all along. So they'll have procedures that we will probably talk about a little later, these video-assisted thoracoscopic procedures, where they have pleurodesis, which means they're going to kind of scar the lung to the pleura inside that cavity, but not have that endo removed. So then you've still got this recurrent cyclic or non-cyclic pain, and you don't have a pneumothorax, but now it becomes very difficult for us to actually access it, because it's now suddenly the lung's been glued to the inside lining of that cavity. And so this, I think, is one of our biggest dilemmas as endometriosis surgeons, is to actually go out and re-educate CT surgeons. I have a case coming up that this patient has had 3 pleurodeses, which means they've scarred the lining of her lung. She keeps having recurrent pneumothorax, and no one has even talked about endometriosis. So maybe I'll turn the floor back to you all.
One thing I wanted to just briefly touch about there was looking at a study that followed all the diaphragmatic cases at this one center in Italy, where there's about 3,000 endo patients that they treated. They found endometriosis involving the diaphragm in about 1.5% of cases. So that's a fairly significant number of patients. And if you were to extrapolate it to our population in the US, that works out to about 135,000 patients who just have potentially diaphragmatic endo. And when you add into it the fact that, again, catamenial or non-catamenial pneumothoraces are a big part of how endo presents, they're probably underestimating the number of patients who have endo related to their lung or their diaphragm. And they're not necessarily knowing what to look for because they don't know all the different presentations of endo. And commonly they'll miss a lot of disease on the diaphragm itself.
Yeah,
and
absolutely.
Endo on the lung is that we can actually see. There might be microscopic or really small areas on the deflated lung that you might not really be able to appreciate that are causing a potential collapse.
Yeah.
And so that probably contributes to some of the recurrences that we see. But the main thing that we typically see in patients who have collapses of their lung are actually little holes in their diaphragm. And for whatever reason, there's a seal on the between the lung and the chest wall. And if we break that seal in any way, and these little holes in the diaphragm are always kind of going through a process of repair. And when there's inflammation, they rupture, and that can potentially break the seal. There isn't a lot of air typically in the abdomen, but just breaking that seal might be enough to allow the lung to collapse. And so that's why that's typically what we really focus on. We look at the entire lung. And a lot of the times the thoracic surgeon will do what we call a blebectomy, where they remove the apical portion or the top portion of the lung, because that's typically where the weakest part of the lung is. And it forms these little these bigger air sacs that are very weak, and they can rupture, allowing pneumothorax. So they'll often do a blebectomy, but they'll ignore the diaphragm. And of course, if they're doing pleurodeses, it makes it more difficult for us to get in sometimes. But endo is much more likely to result in recurrence or recurrent collapses. So about 40% of patients who have recurrent collapses probably are endometriosis related. So that should be a really big red flag for thoracic surgeons, because spontaneous pneumothorax, if you look at the literature, only recur about 5% of the time. So if they're going back in and doing 3 pleurodeses, they should be asking themselves, why is this happening? Because it just shouldn't happen spontaneously that many times. And so, that's where we end up seeing a lot of those patients, because they've had a pleurodesis and it's failed. And, the patient has kind of educated themselves, and they end up coming to us because they're still having collapses despite, a thoracic surgeon going in there.
Indeed.
Indeed. And actually, there's a lot of comments on our Facebook page about people who have had recurrent pleurodesis and then were never told they could have thoracic endometriosis. So exactly what you guys say is happening. Good to know. And I'm curious, let's talk a little bit about imaging, which you may have slides on or not. So how
Can't give away my whole talk for the summit.
No, you can't give your whole talk because people still have to purchase a ticket to come to the Endometriosis Summit. Let's talk a little bit about imaging. In both your practices, how do you like to evaluate the patient when they come to you? Dr. Moling.
So I will say that very rarely have I had a patient who came and said, they had an MRI showing some blebs on their diaphragm. I think it's missed over and over and over again. And it's also missed by other surgeons who've done endometriosis exploration and over again haven't adequately assessed the diaphragm. And I can show a little video clip about, how I look at if you want, if I can show a little clip about how I look at the diaphragm and how you can find it when you first think you don't see it. But how do I think about it ahead of time? Really, I begin with the history. And my history includes all of the pelvic things: dyspareunia, painful sex, painful periods, generalized pelvic pain, painful bowel movements, infertility, rectal pain, a lot of the pelvic stuff. But it also includes, are you having chest pain? Are you having palpitations? Are you having any discomfort in your shoulder blade? And very rarely do patients, I think it's far more rare for me to see, history of pneumothorax. They get routed differently, and they get it discovered a little sooner than those patients who just have this diaphragmatic disease. Pneumothorax is kind of a bigger thing. You end up in the ER and you get discovered. Whereas if you just have diaphragmatic disease, it can go a long time before someone finally discovers it. You might have an MRI, it's negative, and we can almost always find it on laparoscopy. So I start with my history, and yet even if someone gives me a negative history, I'm looking up there. So would you like me to try sharing again and show you?
I would, because I was going to mention Dr. Fogelson gave a talk, your partner gave a talk at AAGL on how everybody should be going up and looking at the diaphragm. And then Dr. Wasson gave the same talk last week. So clearly this is the message that the excisionists are trying to get out to the world. Go ahead.
Yeah, definitely. Definitely. Okay. So this is a super short clip. The first one I'm going to show, and let me screen share and then I'll enlarge it so I don't lose everything. Okay. Y'all can see that, right?
Yes.
I'm going to make that a little bit bigger. This is the short clip, but it's nice because you first think, oh, this diaphragm looks great. There's a liver. This is all great. Wow, no problem. This person doesn't have anything. I'm looking, there's the triangle ligament. I'm looking a little farther. Oh,
liver and took a look.
boom, that's it. There it is. So this is one of the things I want to emphasize, is that I think most surgeons take a peek. They look up there, but they don't really look, right? And let me see if I have another clip where
While
it's
you're looking for that, I'm going to ask Dr. Cernovo a question. I get from the generalized field that they don't go up there and look because they're going to cause adhesions just by moving everything. What is your response when the generalists like to say that?
Well, it's very uncommon for that to happen. Okay. You have to do quite a bit of damage to the capsule of the liver or to the diaphragm itself to get any adhesions. Even when we excise the disease off the diaphragm, very rarely does it result in adhesions if you're just removing the disease itself. There have been some doctors that I've seen that take huge areas of diaphragm that even look normal, and that I think can result in scar tissue, and that's why I don't just indiscriminately remove normal looking tissue. I really try to focus on the disease itself. And having done, almost 1,000 cases, I think that that's enough for the great majority of patients. And so, scarring in that area should not be a concern. Does touching the ovaries cause scarring? No. Does mobilizing the bowel cause scarring? No. So, that argument doesn't really hold up a lot of water.
not at all, not at all. And I think that I really truly believe that adhesions from surgery are much less painful than adhesions from endometriosis, and that leaving the endometriosis causes far more pain than excising it, leaving a few filmy adhesions between the liver and the diaphragm. I think most patients wouldn't even notice it. So I think relatively it's really important to find that disease. So along the lines of what we do with Nick, what Nick similarly does, Fogelson, every patient I put them where their head is tilted up, which is called reverse Trendelenburg. And before I dock my robot, before I really begin the case, while I'm exploring everything, I look in the pelvis, and then I tilt them upward. Sometimes I'll even airplane them a little bit to one side or another. And I lift the liver. This is underneath the liver. You can actually see the surface of the peritoneum over the right kidney here. And you can start to see up in the corner, these are some lesions of beginning to see endometriosis. So let me just play you this clip also. It's another super short clip, but it just, look, right there. Once we mobilize this liver and look, we can really see that is just terrible disease. Mobilizing the liver like this, you can also see how I'm going to be able to access it to excise it. Sometimes you need to lift the liver up to get that disease. This is under that triangle ligament. There's the triangle ligament. The disease is under that. So sometimes you need to release that ligament to be able to better access the diaphragm. But this is very painful disease, as you can see, as you can guess. Good.
It's funny because we offer 3 days at the Endo Summit, and one of them is a lot of surgical videos, and patients email me and they go, why would I want to come to that? And I say, because your mind will be blown, because not everybody learns just by listening. Some people need to see what's really in their body. This is such a perfect example of that. Dr. Cernovo, do you see diaphragmatic endometriosis more on the right versus the left, and why might that be?
Well, yeah, we definitely see a lot more endo on the right, well over 90%, I think, 90, 95%. And in fact, if we don't see, we often do a thoracoscopy as well for these patients to maximize our chances of identifying all the disease that's really far back on the diaphragm that you might not be able to access as well, either laparoscopically or robotically as well. And I feel that we sometimes miss some of the disease. And that's why when we do a thoracoscopy, we actually pick up an extra 5 or 10% of the disease that might be there. And so that's what we've been doing for over 15 years now. When we have a really high index of suspicion that there's endo involving the diaphragm and or the chest. And we really don't know why there's an increased incidence on the right-hand side. There is a theory that there's a clockwise rotation of the fluid within the abdomen. Unfortunately, those studies were really poorly done. And we don't know how accurate that rotation of the fluid is within the pelvis and abdomen. If that were to be true, then there would, cells in the pelvis could transplant there and get lodged there. Some doctors like Redwine and others feel that during embryologic development, the way that the fetus and the embryo develops, it will actually have a propensity to leave the disease more on that side than on the left side. So really, the question is still a little bit up in the air, but it's definitely way more common on the left or the right-hand side than the left. Collapses are typically more common on the right than the left as well. Almost all the hemothoraces that we've seen have been on the right-hand side. And almost all of them have been in African or African-American patients. So there's something definitely genetic there as well that explains that difference, why we aren't seeing patients with hemothoraces who aren't of African descent.
Yeah, so
the same increased propensity for hemoperitoneum as well with
yeah.
And
the good thing about that is once you treat their pelvic disease, the hemoperitoneum improves. In the great majority of patients, I very rarely had recurrences of that. And the same thing with the chest endo that's there. There's often holes in the diaphragm as well that allow that fluid from the abdomen or pelvis to get into the chest. I don't know which way it's going, whether it's going from the chest into the pelvis or vice versa. I think it's probably because the fluid is coming from the abdomen and going into the chest, because almost all those patients have disease in their pelvis and fluid in their abdomen and pelvis as well.
Yes. So, how much do you rely on imaging before you make a surgical decision? I know the majority of your patients have already been to many places already, but I'm wondering, Dr. Cernova, how much imaging do you use?
Well, because I'm working with a thoracic surgeon, they want to rule out other causes of chest pain in those patients. So all of our patients have a CT of their chest to make sure there's nothing else going on. Okay. Every now and then we'll pick up something else that we have to investigate to rule out as a cause of their pain. They all have pulmonary function tests to make sure that there isn't something that explains their shortness of breath. Maybe they've got, a problem with asthma, or some problem with their lung function that prevents them from getting proper oxygenation that may need to be addressed. And so we want to know those things before surgery when we're going into their chest. There was some of the literature suggests that we should be getting MRIs on these people. Unfortunately, MRIs, again, like Dr. Moling said, are uncommon to pick up disease, I think. It has to be above a certain volume or size of disease for them to pick it up. If you're concerned about diaphragmatic disease, the diaphragm should be visualized the great majority of the time with an abdominal MRI, because they are getting they want to go to the top of the liver. And so they're usually being able to see that disease. So you may be able to pick up some disease with just an abdominal MRI. And that's probably going to be just as effective, because most radiology departments don't have a lot of guidelines for doing thoracic MRIs. I think it's really something that you may see in a university setting where, hey, let's do a thoracic MRI, and they don't run into any problems because they are in an academic setting. Whereas in reality, insurance companies don't like to approve thoracic MRIs because the radiologists don't have a lot of guidelines for it. And, they just feel that thoracic endo is so uncommon, it's a useless test.
Yes, there were a lot of comments today before the webinar that people, can they have disease with negative imaging? Because a lot of people are going to doctors and they go, well, your imaging's negative. So I was glad to hear you answer that question. So here we go, where we have a high suspicion of diaphragmatic and thoracic endometriosis. We go to a good specialist. What are the treatment options? We'll start with you, Dr. Moling.
The treatment options, if you know you've got diaphragmatic disease, or
well, if you suspect that you're
Yeah.
a patient, you have horrible shoulder pain, you have
Yeah.
maybe a little shortness of breath during your period, you go to the doctor. How might we treat thoracic endometriosis or diaphragmatic? Well, we saw the diaphragmatic, but what are our treatment options?
So I think that actually, I think Kenny referred to, I really like PowerPoint. I like the visual. So I'm gonna screen share again with y'all, because he referred to the series of 3,000. I think that's Marcello Ceccaroni's work you're talking about. And Marcello has his plan for treatment is that if it's a small foci, you can do superficial destruction or ablation with argon beam or some kind of fulguration. I actually prefer to excise even shallow lesions, even if they're not full thickness lesions. I like to excise them myself. But this was their recommendation from that big series: plaques, diaphragmatic peritonectomy or focused excision, and nodules, full thickness diaphragmatic excision. So what I tend to do when I know someone has it, I'm planning ahead. I might make sure that I have a surgeon who could do VATS on hand if needed. And at the same time, I'm also comfortable that I'm going to excise that disease. And if you have full thickness disease, as you're excising it, you can tell, you end up getting into the cavity, then you can look inside at the lung from the abdominal perspective as well. So I've done like one case of argon beam, and I felt like that's not as effective as excision, even superficial excision or full peritonectomy for really widespread disease, and then full excision. I want to show another picture. If I screen share again, I hope you don't mind my going back and forth, but I'm a picture is 1,000 words. That's a peritonectomy. I want to make sure everyone in the audience has a sense of what VATS is. Like what is this VATS thing that we're talking about? So it stands for video assisted thoracoscopic surgery. And if it's just a look-see, it's going to look something like this. So what you're seeing in this picture is, if you can see my cursor, this is the rib margin down here. And so in between the fourth and fifth, usually intercostal space, the surgeon will put a 5 millimeter scope, so a tiny scope, directly into the pulmonary cavity. And that way we can see, if you want to see just the top of the lung, this is how from the pleural surface inside the lung, you can see how an endometriosis full thickness lesion looks. And I don't have pictures of it with me today, but you can also see if there is disease on the lung itself. So I think VATS is a very important tool and component, and having someone available who is either planning to be there, or we're lucky here in Portland that we have most of the time, if we stumble on disease that the patient didn't really give us clues about ahead of time, but they want us to go ahead and remove all disease, even if we find it. In that case, sometimes we'll need to do VATS to look above as well.
Dr.
Sterner,
how do you prepare your OR and your patient who's going to head in for a VATS? It's always known ahead of time. It's on the fly decision. Sometimes it's a little of each. What do you do there?
We typically will have planned all of our thoracoscopies. The one exception maybe being someone who, we look at their diaphragm, maybe they've had a history of collapses, they haven't really complained about it too much, and we go in there and we see these big holes in their diaphragm, and then we will typically take them, do a VATS on them as well. But the great majority of them will have been planned, and the reason that we do that again is to make sure that we're not missing any disease. And this is how we've been doing it for over 15 years, this way we can get the disease that is typically a little bit more difficult to reach posteriorly, which the lung can or the liver can be in the way when you're approaching it from below, and sometimes it can be very difficult to access even when we mobilize the liver as much as possible. Those superficial, so usually what happens is the great majority of patients have both pelvic and either diaphragmatic or thoracic symptoms. It's pretty uncommon to only have disease involving either your diaphragm or your chest. And so usually what we will do is we will do the pelvic and abdominal portion of the procedure first. So we will go in, we'll do everything in the pelvis first. Then I will look at the diaphragm where, again, we tilt the patient's head up. We may tilt them away from the side that we're wanting to look at. So if we're trying to look at the right side, we'll tilt them to the left, and that pushes the liver away from that area. And we use a 30-degree scope, and we may actually put an extra port right below the rib cage. And when we use that 30-degree scope, we can look all the way to the very back of what's called that costophrenic angle. And that's the angle between the liver and the chest wall and the diaphragm. So that way we can completely visualize the posterior aspect. And then we can also do some maneuvers so we can see the posterior aspect of the diaphragm as well by lifting up the liver and visualizing the backside and lateral side of the liver as well. When we're done everything in the abdomen and pelvis, then what we do is we reposition the patient for a thoracoscopy. So we put them on so the side that we're operating on is on the upper part of the table. And then what the thoracic surgeon does is they re-prep the patient in that position with their arms out to the side so that there isn't any nerve impingement. And then he goes in again between the 5th rib and sometimes down to the 7th rib if he has to add some more ports. And then he will go about examining the diaphragm thoroughly and the chest wall and the lung itself to make sure that, we're identifying all the potential disease that's there.
Yes, I wonder. So I'm probably the only one out there wondering this. With our POTS patients, are there any concerns with so much tilting up and tilting down and tilting up and tilting down?
Typically, if they're well hydrated, that's not a problem, and it's not like they're going from, sitting to standing. It's not that dramatic a change. And so we really haven't noticed any problems. POTS patients, while it seems to be an increasing diagnosis that we're seeing, I still think that it's relatively speaking a small percentage of our patients, maybe 1% of our patients have POTS as well, maybe a few. And as long as they're adequately hydrated throughout the entire surgical process, I think we see those falls in blood pressure that they're concerned about.
And they're being concomitantly monitored by anesthesia and medicated if their blood pressure is dropping and observed, or increased fluid hydration. I do feel like there is a higher percentage of patients with POTS in my endo community than in my former general patient population. But I don't know that that's been fully looked at yet. And so I have a question for you, Dr. Cinervo. One of the things I find tricky is when someone has had pleurodesis before and they did not yet get their diagnosis of endometriosis, and they have pretty significant recurrent symptoms of the chest, and yet they've had pleurodesis. What's your protocol and how do you approach them?
Well, again, it depends on how many pleurodeses they've had. Okay.
Mm-hmm.
And when they continue to have chest pain, the concern is that there's disease still there. Okay.
Mm-hmm. Mm-hmm.
And so, we counsel the patients that if we go into the chest and we try to access the diaphragm, it may be more difficult. Okay. And when we get in there, if the lung is scarred more to the chest wall and or the diaphragm, it may be more difficult to visualize that disease because, you have maybe a raw surface and you might not necessarily be able to see some of that disease there. And the other concern that when you do that is that you may increase the likelihood of a little bit of damage to the lung itself, and the patient may get what's called an air leak. And so when you have an air leak, what you have to do is after surgery, a patient has a chest tube and we're trying to reinflate the lung, but the machine that we use to try to reinflate the lung is very helpful nowadays. It's not like it was 20, 30 years ago where it was just simply a tube that was hooked up to the wall and there wasn't any information that was given. Now the machine that actually produces the lung to expand, it actually has diagnostics in it that tells us whether there's an air leak. And so what sometimes has to happen is sometimes you have to go in and you may have to do some other procedures where you're putting in some thrombin or something like that, or some other type of material to try and seal off that air leak. And sometimes those patient stays, instead of just overnight, could be several days. I've had, some patients who've unfortunately had prolonged air leaks that have, been in the hospital for over a week. That tends to be the exception rather than the rule. I'd say, well over 90% of patients are discharged the next day. And occasionally some patients, when they have extensive disease and extensive scarring, may be there longer. And those are definitely patients who are much more difficult to treat because of that scarring. But you kind of have to go in with eyes wide open, letting that patient know, how to best manage that and what the additional risks are of it. And sometimes we get in there and we might not be able to find the cause of their pain because of the scarring there and the inability to, you know, see the disease there because of how much scarring had to be taken down.
Yeah.
But sometimes we'll get
And-
in and there won't be any scarring at all.
Yes, and I have one coming up, and on chest X-ray, there's a complete airspace between the lung and the diaphragm where it was supposed to have been pleurodesed. So
Then that's reassuring, because then I think you have a much better chance of getting into that space.
yeah,
And you know, if there's already a pneumothorax there, then that's a lot better prognostically than you've got a patient who doesn't necessarily have a pneumothorax or
Yeah.
anywhere, or it's in another area that isn't related to the diaphragm.
yes.
No, it's interesting. You guys said, "Oh, I don't know about the POTS and endometriosis." I have like 15 questions about POTS now.
Now we
Um,
need to
so-
add that to our
yeah.
next webinar.
Well, we have that we're doing connective tissue this year. But to find a good POTS speaker, I've been on the hunt now for like 3 or 4 years. So we have some questions. We have some questions about thoracic outlet syndrome and how often you see that as a misdiagnosis, but also does the way the disease restricts movement contribute to thoracic outlet syndrome?
Well, thoracic outlet syndrome is a condition in which there's some distortion of the anatomy involving either the nerves coming out of the chest, right at the very apex of the chest. And typically those patients are not going to present the same way that someone with endo presents, okay? So they're often going to present with either, there's different types of thoracic outlet. You can have vascular and you can have neurogenic. And so when there's a compression of the blood vessel, often the patients will have difference in blood pressures in each arm. And that may be one way to detect it. And then often the patients will have different symptoms. So they may have poor pulses in their hands. They may have weakness or numbness in their hands, which reflects that nerve or the blood vessels are being compressed. And it's usually unilateral. It could be, left or right side, whereas endo is definitely more right-sided for the most part. And, the fact that you have thoracic outlet syndrome shouldn't necessarily affect, or having endo shouldn't necessarily affect your thoracic outlet syndrome, because they're probably both independent things, okay?
Yes.
And so whatever's going on up here is not necessarily related to a collapse in the lung or, disease on the diaphragm. They may have some discomfort up in their shoulder, but they're going to also have those other symptoms that make you concerned about thoracic outlet syndrome and get an MRI of that area to look for the abnormal anatomy where there could be an extra rib or the blood vessels in the nerve going above a rib that they shouldn't be going over.
Yeah. So I would concur. And so in thoracic outlet syndrome, these scalene muscles, as they attach to the first rib, clavicle, the thoracic outlet of the venous and arterial complex and the nerves, as they pass through those muscles underneath that first rib, they can get compressed, and then you get this swelling in the hands, arm pain, tingling in the hands, unrelated to that internal cavitary process of endometriosis. In my experience, that they're very separate issues that even present differently. The symptoms are really different. And I would think, Sally, you would see more patients with thoracic outlet. Yeah, right.
Right. So I was going to say thoracic outlet syndrome and also costochondritis, which are two things that came up for people online today. They are in some ways musculoskeletal or manual bone joint vascular based. And so typically they have no relation to any cyclical nature, but you can go there. There are very good therapists that just do thoracic outlet syndrome, much like pelvic PTs. They have all this extra training. And you can test out, does this cause more pain? Does that cause more pain? The way the head moves, the way the neck moves, how you can move the first rib. And if all that is irritating you, typically not endometriosis, but also the same with feeling that connection between the ribs and the sternum, because you're not going to have usually that insane tenderness. In my experience, that the joints would be inflamed with a thoracic endometriosis. Do you guys feel
Yeah,
the same
and
way about?
with costochondritis, it typically is involving the central area, right where the ribs join the sternum. And so it's that cartilage that is inflamed, okay? And they'll often respond with non-steroidal anti-inflammatories and certain exercises in that area. Whereas patients with endo, no matter what you treat them with, they don't get better, okay? And they'll often have a progression of their disease over time. Whereas typically that's going to be fairly static and improve over time, whereas endo-related pain often gets worse over time. It may just start with your cycle, but it may become full all the time as well, involving your shoulder or neck or chest 24/7.
So since you brought it up, I see we're running short of time, but since you brought it up about pain in this area, I do want to bring up that some patients are going to have post-operative VATS pain from the insertion of those scopes in between the ribs. And that can be really painful. In my experience, it's more painful than their recovery from the abdominal incisions from our robotic procedure and our laparoscopic procedures. And that physical therapy to help release those intercostal muscles, to release the adhesions from the laparoscopic VATS, thoracoscopic, I should say, incisions, can be a really important part in the recovery after these procedures.
Yeah, I definitely encourage patients, if they're having pain beyond 12 weeks, to follow up with a physical therapist to kind of, and I give them stretches to do, like standing in a doorway with their arms like this and stretching their chest, and same thing above their head in the doorway to stretch their chest, and doing stretches from side to side, where they're extending their arm above their head to try to stretch that area out. And sometimes it does, there is a nerve right under the rib that sometimes you can get some neuropathic pain from, that may need some therapy. And very rarely do they need, something like a block or other therapies like Lyrica to help address that nerve pain. And typically in the patients who have more prolonged pain, it does eventually get better. It's very rare for that to persist, beyond 6 months.
I will say, I feel that this particular population, if you think about the diaphragm being sort of the roof of what we call the pelvic floor complex, because the pelvic floor and the diaphragm work together. And we had a huge webinar on this where we talked only about this concept about 2 weeks ago, that this is the population that should pretty much automatically go to pelvic PT, not just to work on the excursion of the diaphragm, the way the rib cage works, even the way the hip flexor is going to work after sort of the surgery has been done, because you have definitely adapted the way you move and the way you function to the disease that was inside of you, likely for way too many years. So we did have a wonderful, with pictures and everything, with Ginger Gardner and with Amy Stein, and I encourage you to go watch that one. So we had a good question. So I used to have Dr. Vidali talk, and then I would manage the questions, but now I have to do both. So the question is, what are the risks of the VATS procedure, and are there any more risks to that procedure than a traditional excision?
Like an abdominal excision?
Yes, abdominal.
Yeah, the risks associated with the VATS that we're doing are pretty minimal. Very rarely you can get a pneumonia. I think I've had 1 or 2 pneumonias out of 1,000 cases. Okay. You can have a pleural effusion, which is a fluid collection in the lung. It's less common to see that after diaphragmatic resection than it is in someone who has had a pleurodesis or something else done for their lung, like a pleurectomy or something like that in recurrent pneumothoraces. Sometimes a pleurodesis isn't enough and you have to kind of go to the next step, which is a pleurectomy, where you remove that lining to increase the likelihood of it getting scarred. And so pleural effusions are very uncommon. Recurrent collapses can occur. They're very uncommon to occur within the first, month or two of the surgery. Sometimes you can have later collapses where, they may have a collapse, say 6 months down the road or longer. Typically, those collapses are going to be much smaller than the ones they used to have. And so sometimes what can happen for those patients is you put what's called a pigtail catheter into their chest right at the point of the collapse. And then they put some of that medication to help, talc or medication to help re-scar that little small area of the lung. And so, yes, you can have, all the different things that can happen with any surgery, like you can have excess bleeding and, things like that. Those types of things are extremely uncommon. The rib cage pain is something that can often happen and persist afterwards. But again, for most patients, that does improve over time.
So one thing we haven't talked much about is left-sided disease. And I just want to touch on that because in my experience, left-sided disease, especially if you have disease over the pericardium, some of the symptoms are a little different, such as cardiac palpitations, a feeling of anxiety, a feeling of doom, and patients are ascribed to have a mental disorder, and really what they have is a small lesion on the pericardium, and those palpitations go away when you excise that lesion. And so I just want to make a plug that, yes, there is that 10% that I want us to remember, and that we do see disease totally can be unexpected on the left side of the diaphragm, and that we need to also be prepared to address that aspect of disease as well.
I'm excited that not excited, sad in some ways that you brought it up, but I'm happy that you brought up this feeling of doom and this sense of panic, because we have a number of comments online that people were just prescribed antidepressants and anti-anxiety medication when they went to their doctors to describe many of these symptoms that you're talking about now. So I think that's really great. I happen to have left-sided disease, so I know exactly what you're talking about. And I was lucky enough that the cardiologist took it really, really seriously. So, but unusual. I think that's only because he knows what I do for a living. So I want to encourage, there are questions that are still out there, and perhaps we'll head to Instagram at some point this season to answer them. But there are questions that could be answered simply by going and downloading. Dr. Cernovo took his time to write this amazing download on centerforendometriosiscare.com. It's a free download. It's like my Bible. Sometimes I sleep with it under my pillow, but it talks all about the things thoracic endometriosis can be confused with, how to rule in and rule out those things, the etiology of endometriosis, imaging, and a lot of these gaps in these questions that you have. Just go download the thing. It's very detailed. I loved it. Also is like a little bit of a tribute to Dr. Redwine as well. And it's very informative. So we're heading into, I think we're 4 weeks away from the Endometriosis Summit. And we end every webinar sort of the same way. Dr. Cernovo will be presenting on Sunday, March 10th on thoracic endometriosis. I've seen the presentation. It is really, really good. And I saw it now, making him redo it because it was so good. We also will have a second presentation by Wendy Bingham on Friday, March 8th on emerging research in thoracic endometriosis. And that's a full 2-hour workshop for patients on Friday, March 8th. So Dr. Cernovo, what are you looking forward to the most about the Endometriosis Summit this year?
Well, I always love the patient interactions there. I love seeing patients that we've operated on before, or that ones are interested in coming to see us. I think it's just a great, venue where patients and PTs and doctors can get together and really try to make a huge impact for education for patients and PTs and for doctors as well. So I think it's a good combination of how that's beneficial for pretty well everyone there.
Excellent. And Dr. Moling will be talking about the microbiome and endometriosis during Endo Summit workshop, which this evening was fantastic. I can only imagine what your workshop is going to be like. Her workshop's going to be in Margaritaville. And I thought it was just very funny to have a microbiome workshop and then eat afterwards. So that's my little sense of humor. But what are you looking forward to the most about the Endometriosis Summit?
Seeing you.
Oh, well, yes. If I make it,
I'm teasing. I'm teasing.
Right.
But when I say that, I mean, I'm looking forward to seeing everyone. And I really love that this conference brings together patients, physical therapists, some surgeons, and like-minded individuals, all of whom are really passionate about this disease, right? We're all on some different point in our process of having the disease, or learning about the disease, or learning how to treat it better. I learn so much from my patients every day, and I learned from colleagues like Dr. Sonervo. It's an ongoing process. So I think the summit, that collaborative experience, I always come away, or my one time, I came away very moved and enriched by that. So I'm looking forward to that.
We're very excited to have you both. We are going to have both Dr. Moling and Dr. Fogelson. And by the way, we have the entire Center for Endometriosis Care Clinic. Everybody that I associate with them, from Dr. Eugenio Colon to Heather Guidon and Wendy Weiner. So tickets are available www.theendometriosissummit.com. It is available virtual with a 90-day recording from anywhere in the world, and in person in Orlando, Florida. If you're heading to us in person and you want to hear that microbiome lecture, you should buy your tickets sooner rather than later, because I just had to reconfigure the room to get more tickets released. So we are nearing sellout for the middle day of the summit. So if you're coming in person, you better buy those tickets. Anyway, we are, I believe, back. Hi, that's my sweetie pie. That's Finley. Dolly is very jealous. She's out for a walk right now. We are back next Monday. I believe we were talking about groin pain, and I'll see everybody soon. Thank you, doctors.
Thank you.
Thank you.
Take care.
Bye.